The intent that
You're talking about your hair, Scott?
yeah, it was I had to break it to her it's gray, not actually.
No longer ginger.
Hmm?
Your hair is gray, not ginger anymore, or is it a
It's gray.
tinge of ginge and a little gray?
The ginge is fading.
That's right. My fondness for you is not based on your hair color. It's your
I appreciate that.
amazing personality. Yeah.
I doubt that.
So we've got folks starting to walk into the or click into the room here. So we'll give them a few minutes as we transition from the morning meeting to the fireside chat meeting. We've been, for the audience as you join, we've been talking about us folks that are aging and getting less original color and more gray and white in our mix. Except Julie, she hasn't changed a bit.
I got good people.
Good people. Yeah, stress-free job. Stress-free job. Okay. Lindsay, we still have looks like a session is live bubble up on the screen. Is that me or you? Don't end the session.
Should be gone now.
Yeah, if these app companies would stop updating software every week, we'd figure it out eventually. But okay, 2 minutes past top of the hour. We'll get going here. Welcome to the October fireside chat. So finally back to somewhat of a season that feels like a fireside discussion makes sense, where the weather at least is getting out of the hot and sunnies and into something a little cooler on the west coast or the northwest anyways. But today's discussion is going to be just a slightly bit different than we've done in the past. Usually we have one guest and we ask them questions. Ernie had this great idea. If we were to ask everybody questions, maybe we can learn a little bit more. So it occurred to me I didn't want to be in the spotlight, so I invited more people. And then that brought in some of the other guests we'll introduce. But as far as housekeeping items, and I don't know, we haven't quite figured this out in like 3 years, but there is a chat button on your screen, which is fine for commentary. But if you could please use the Q&A button for questions, makes my job a heck of a lot easier as far as keeping track of what I'm doing and who's asking questions and whose questions have been answered. And as always, we will filter those into the discussion as we go. If it makes sense during the moment, I'll ask it then. If not, I'll kind of push it towards the end to put it into a category all its own. But you guys have always done a great job of asking good questions, and you got a lot of knowledge on this panel today. So fire away. So with that, let's go ahead and click forward to the next couple slides, Lindsay, and we'll do some introductions. But Ernie Clevenger, Ernie, when was the first My Health Guide that you sent out? What year was that?
Oh, it was before you were born, probably 35 years ago.
All right. So I started in this business back in 2003. I think the date was. I'm like 21 years into this thing, but I was just a young whippersnapper back then. But Ernie was a source of information and knowledge for me that I've used and still use today, all along. So I've been reading that newsletter from the beginning, and I've always appreciated him putting that together. I know that can't be something that's easy to do every week. And then along the lines in my early years, I ran into him at a golf course at a SIA event. I think we shared a cart together or something, and I've always appreciated everything he's contributed to the self-funded world along the way. So pleased to have him on as a guest today. And then also joining us will be Julie Bobak, who also goes way back in my history. I think may have been one of the very first travel meetings I did in 2003. She was working at Zurich back then and up in a big tower in downtown Chicago or something. But She, I don't know. She took me in and listened to what I had to say, and I got some business out of it then. But we've worked together ever since then, and I've always appreciated what she brings to this industry, what she's helped me with. She asked me not to mention anything, but she is also getting to a point where I think she's going to spend a little more time on the beaches of Florida versus the offices of Florida. So, Julie, appreciate all you've done. Congratulations on what is a upcoming retirement, but wonderful having you on the call today. And then to balance out the panel from the 6 degrees side, Scott Ray. I'm just working all kinds of people I've worked with for a long time. So Scott and I met back in 2008 or something like that.
Oh, 6.
6. Don't want to short you a couple
Yeah.
of years with me.
Yep.
And then obviously went from that company, put 6 degrees together, and we've spent a lot of time in meetings and boardrooms and everything in between. So the new face on the screen, David, sorry, I haven't known you quite as long as these guys, but David, who is general counsel with 6 degrees, is going to be helping us with some of the legal questions that came up. So David, welcome to Fireside Chat. Also your very first Fireside Chat, isn't it?
Yeah, absolutely. Thank you for having me too. I appreciate it.
All right. Well, is that a little gray in your beard? Is that new?
Yeah, it's getting there. It's catching up to me. So that's
All right. So
I'm well seasoned to look at it.
Perfect. So Ernie, why don't you just do a quick hello? We'll do a quick round of that. I did my version of it, but let's let everybody have a moment to speak. We'll start with Ernie, then go to Julie, Scott, and then David, and then we'll get started on the discussion items.
Well, thank you, Heath. I always look forward to listening and participating in the 6 degrees Fireside Chat. I love reporting about them. I like to listen to them, and to be a participant today is an honor.
You want me next, Heath?
You're up, Julie. What do you got?
Okay, yeah. I kind of echo what Ernie's been saying. I mean, I've done some sessions for the 6 degrees team and worked with them on many projects over the years, but this is my first time appearing on a Fireside Chat. So I'm really honored to have been asked. Thank you, Heath.
Is it really your very first Fireside?
It's not the first one I've attended, but it's the first one that I've.
Well, I'm sure you've
Yes.
probably attended,
Yeah.
12 per year for the last 4 years. So you're
Pretty
like
much.
48
If I missed
Fireside
one, I'm
Chat.
sure I listened to the recording.
Yeah, I'm sure on your drives you're got us streaming. I appreciate that. Well, welcome. And then Scott Ray.
Hey guys, yeah, just echo what Heath said. I'm very thankful to have Julie and Ernie both here. Just amazing careers in this industry, and they've contributed so much. So wealth of knowledge. And David, I'm going to shortchange you. Thanks for being here as well.
David, I think most people probably know who Ernie and Julie and Scott are. Why don't you give a little background on yourself, and then we'll get
Sure.
started on this thing.
I've been an attorney for over 20 years. I used to do pharmaceutical and antitrust litigation, but I transitioned into the self-funded world about, I want to say it was almost 10 years ago. I think maybe about 8-9 years ago, when I worked for a small cost containment company. And actually, it's Bashert that I'm here with Ernie, because is your newsletter that brought me to 6 Degrees Health. I think they were advertising positions or whatever, and I'm just like, yeah, I'll give it a shot. Why not? How often do you find a lateral move in this kind of business, right? It's such a small world that it was just everything was meant to be, and I'm working for amazing people, and I've enjoyed every moment of it. So this is, as everybody knows, this is an amazing industry. It's so dynamic. It's
Uh-oh. Can you guys hear David? David, you went on mute there. I guarantee you said something profound. It was amazing. But
I don't know where I cut off. I apologize for that. Anyway, I was just saying that, it's been great working here and working in the self. And just, yeah, this is a great place to be for sure.
All right. Well, welcome to the conversation. So when we were putting this one together, we wanted to kind of cover the spectrum of history and start with kind of a reflection on, what PPOs were designed to do originally, what became of PPOs, and then how that is developed into, some of the areas that 6 Degrees gets intimately involved with RBP, and then some of the changes that we're seeing out there and IDR and NSA and how that applies to all these things. So we're going to cover a pretty good time span of information. But Julie, why don't we start with you, having had some experience in that PPO space, and kind of just give an overview of, what was the original intent there, and ultimately where did we end up going with it?
Sure. So this is a little bit of a health insurance historical flashback. The health insurance business in the 70s was quite straightforward. Most health insurance carriers, including MetLife, Prudential, Aetna, and of course the Blues, all offered health insurance plans that provided a scheduled amount that they would pay for each service right in the policy, and providers and insureds knew exactly what was going to be covered by insurance. If you think about that, and if you don't remember anything else I say today, we actually started out in a reference-based world. I mean, that's what health insurance was all about, where there was a set amount that would be paid. Ever since 1929, health maintenance organizations, or HMOs, have also existed. But in 1973, Richard Nixon signed the HMO Act, which required employers of 25 or more employees to offer an HMO option in addition to a traditional indemnity option if there was one available in the area. Along the lines of around 1980, Golden Rule Insurance Company was a little insurance company in Illinois and Indiana, and they introduced a product which they called Inflation Guard. It was actually an individual medical product, but it covered the entire cost of medical services after a deductible and copay. It wasn't based on a scheduled amount. It actually was called Inflation Guard because as prices went up, it paid more. And this concept really flipped the script on group insurance, and it issued in the era of major medical coverage. We've come a long way since those scheduled plans, and major medical became the norm. And that's really why PPOs entered the scene. PPOs tried to offer a middle ground. There were much lower costs in HMO plans, but they really didn't have much flexibility back then. And Blue Cross of California was actually one of the first insurance companies to offer a PPO plan in 1980. So the goal there was to be able to steer people to certain providers and get better pricing from those providers as a result, much the way that HMOs were doing. But hospitals and providers quickly figured out by setting the price artificially high, they could offer big discounts without actually cutting their prices. After all, it makes sense. Furniture stores, automobile dealerships, and many other industries had been doing this for years. And hospitals were able to take it a step further because prices were really opaque and not available until after the care was provided. So by 2000, medical inflation was really off the charts, outpacing all other consumer goods and services. As a result, self-funding and stop-loss insurance really began to take off. Stop-loss became a highly desirable line of business for the large P&C companies due to short tail and relatively low cost of entry. It was also a phenomenal growth engine for the medical insurance carriers, the BUCAs, as well as for large life insurance companies. But all of these stop-loss carriers at the time built very large books of business that support the PPO model. Carriers are dependent on the PPO model, and large brokers favor the PPO model because they're able to achieve growth year over year that's desired based on the excessive trends that we're seeing in the PPO marketplace. So the emergence of reference-based pricing has been seen as an unwelcome disruptor to the large carriers and the carriers with networks. It's also initially was meant as a with disfavor by the stop loss carriers whose profitability and growth depend on their commitment to the PPO model with their unsustainable healthcare trends. Within the last 10 to 12 years, a few carriers and MGUs that were newer entrants recognized that PPO costs were unsustainable. They do nothing to contain costs, and they were attracted into the stop loss market when TPAs and vendors that specialized in reference-based pricing were demonstrating real cost containment. And this is those folks that were actually taking the percentage of Medicare approach. Without a large book of business that depended on the old PPO relationships in the PPO world, these newer underwriters were able to gather enough data to assess the impact of RVP on stop loss pricing. And if they didn't have to support a big book of PPO business with the high levels of trend and leverage trend there, they were able to offer very different pricing to their clients. There are now really good tools to be able to appropriately price and write the business, and these carriers are seeing much better margins. And as a result, we've seen some of the other bigger carriers that have had the major books of PPO business and are not owned by a network or a company that owns a network. We've seen them actually migrate toward writing some RVP that in the last few years as well. Now, we have seen some provider noise that's led to some migration away from RVP by some of the early adopters, but between implementation of direct contracts with an RVP wrap, RVP safe harbor contracts, this is mostly what we see in the marketplace today, and also balance bill solutions that protect the member against balance billing. As I look at our book of business, the cost escalation that we see on catastrophic claims in the PPO world is just still exponentially higher than what medical trend is. So if we assume that a PPO trend is for medical alone without the RX component, somewhere around the 3% range of Medicare, and PPO trend is maybe more like 8-10% for medical only. When you're actually looking at catastrophic claims, you're seeing much higher trends definitely in the upper teens and low 20s in terms of double digits in terms of what we see year over year for those high cost claims. But I really feel like pricing transparency, getting rid of gag clauses, ERISA fiduciary lawsuits, everything is now setting the stage for RVP-based products to really shine and replace PPO plans.
Hey, Julie, I have a couple questions for you. If you go back to, the early days when you had the schedule of benefits, more of an indemnity type solution, you kind of compared that to RVP today. But back then, did you see hospital prices with such variance that you see today? Or did the actual hospital prices bear a little bit more of a tie to reality?
There was some variability with the big tertiary centers, but much closer and much more, like you said, tied to reality. And employees and individual policyholders that had these plans in place, they had a choice. They knew that they were going to have to pay for whatever the hospital charged. So it really did hold things down until the major medical plans kind of took over.
Right. And so you alluded to this, or you said it, that as, the PPOs kind of took over, that bill charge amount kind of detached from reality because, the contractors wanted larger discounts, and it's this ridiculous game that we play. And that's why we see, gross charges on hospitals can range from 2.5 times Medicare to 25 times Medicare for the same service.
Yep.
Well, Julie, you are now my favorite historian, so thank you for walking us down. Your conversation led to two thoughts. One is in the 90s, we had a program called the CRVS, the California Relative Value Scale. And it was a hospital CPT like arrangement that multiplied times a fixed amount. And that's what generated the cost. And it worked. It saved money for the employers. However, the providers claimed foul, and it was declared antitrust by the FTC. And we had to abandon the CRVS. The RBP, the reference-based pricing today, is close in flavor to the CRVS, but now it's legal and it's still having a favorable impact today. The second comment was about PPOs in general. PPOs used to work. That's when you could direct a certain claim or set of claims or employer to a given set of providers. And that worked because that provider who received steerage, who received the business, would offer a valuable and measurable discount. Good news.
Mhm.
However, as PPOs grew and competed and so forth and merged and so forth, the PPO became ubiquitous, all providers. And therefore, there's no steerage, there's no discount. And that's why I feel that the PPOs lost their legacy. They lost their value because they were gigantic. If that's true, then I ask the question, what do we need to be asking about RBP as it becomes ubiquitous, as it becomes widespread? What lessons can we learn from the PPO debacle to keep RBP valid?
No, you want to take that, Julie?
I was just gonna say, the first thing that comes to my mind is the reality of the reference point. You know, we think that Medicare is a reasonable reference point in most areas. And it does have some outliers that can apply. But if that were to change, if through politics or whatever, that became another game like Charge Masters became, you know, we'd have to find another solution and perhaps cost, but even that can be manipulated. So
Yeah. Yeah, and I think, you know, some people do like to attack RBP based on Medicare as a methodology, and there is quite a bit of documentation out there about Medicare pricing, and if you are interested, you can go Google MedPAC. It's Advisory Council of Congress, and they, you know, they do all the research into Medicare pricing, and last time I looked, I think Medicare was designed to produce about an 8% marginal profit. It was somewhere in the 6 to 8% marginal profit to hospitals. So it is a solid benchmark. But I agree with what Julie said. But I also think the other thing I would add there too, Ernie, is I've always kind of thought of RVP as kind of a catalyst for what I think is happening in the industry, which is this pendulum swing away from kind of broad-based saturated networks, and that have lost their value to providers, and a result don't see a lot of benefit in terms of economics from them. So you're seeing this pendulum swing back to narrower networks, similar to how PPO started. And I think RBP helps facilitate that. Some plans do go complete naked RBP, but I agree with the statement that the trend is to supplement that approach with direct contracts with narrower networks, and that's really the sweet spot that we're trying to get to.
And Scott, as you talk about narrower networks, is that not a return in concept to the original PPO, which was
Yeah,
a narrower network than the market at large?
absolutely. And I came from the transplant network world, and we've seen the same thing happen in that space. If you go back to the early days of the transplant networks in the 90s, the COE networks were 40-ish hospitals nationwide. If you go look at them now, and if you go look at the Centers of Excellence networks and then look at all the transplants that are done, they're covering probably 90+% of all the transplants that happen in the US. So it's almost this kind of natural evolution of a network to grow and kind of lose track of its original purpose,
Mhm.
unfortunately.
Heath, a question about RBP for my education. If it's a Medicare reference that you're using, how do you handle claims that are pediatric or OBGYN, births? Because there are not many activities to benchmark in the Medicare world.
Yeah, we don't just use Medicare. It's impossible to do. So there's multiple benchmarks that get pulled into this. It, I think, just from a general description standpoint, it's a multiple Medicare, but the reality is there's a lot of other benchmarks that have to be used in order to come up with something that makes sense in some of those procedures.
Yeah.
One of the things that I was sitting here thinking about is we talked about the evolution of PPOs and how they were diluted. And I think about our clientele. It can be all over the board in terms of what they're trying to accomplish. I think everybody wants to save money. Some of them go into RVP thinking, I'm gonna do pure RVP. I'm gonna get away from contracts and all these things. And then, one of the things that can come up in an RVP environment is access. And people want to maintain access. And Ernie, you alluded to this, and I think Scott, I know this is something you and I have talked about, but probably good for discussion here is, where's the balance to keep RVP from becoming something that is no longer RVP? And I think it's understanding the different client desires that are out there. Some do want to maintain that hard discount if they can get it. Others are looking for an easier path.
Yeah, I think, Heath, this is where vendor selection, I think, makes a big difference in RVP, because you will find some RVP vendors that have kind of a one-size-fits-all approach, and if that is the right size for your plan, then fantastic. But then there's other vendors, 6 Degrees is one of them, that we build flexibility into our solution. And as Heath mentioned, we have clients that are 100% focused on savings, and they're not interested in solutions to deviate from that. Whereas we have other clients who are very sensitive to disruption to the patient. They don't like access issues, balance bill issues, and they're willing to sacrifice savings. And so, there's a number of ways that you can slice and dice RVP. It isn't just this, one size fits all solution.
Do you think that the on-site clinic, which is dear to my heart, is a form of RBP? In other words, the resource is the cost of the physician, the cost of the clinic, the cost of the medications. It's all on site. It's a very defined cost, and they're taking over much of the primary care lift for a given employer.
Yeah, Ernie, I'm a huge fan of that solution, as well as direct primary care in an RVP setting. It gets people most of the care that they need. And then, you can also work with those vendors on referrals to specialty care when necessary. Help giving them information about providers, specialty care providers or hospitals that have a history of not playing nicely with RVP. So it is a great accessory in an RVP plan.
There was a discovery that you probably already know, but it was new to me, that the network that needs to be around an on-site physician that she needs or that he needs is only 28 people. There are 14 disciplines. There's cardiology, endocrinology, nephrology, OBGYN, pediatrics, etc. And most doctors, including your own, if you were to ask him or her, who's your favorite cardiologist? And she will say, it's X. Well, who's your backup? It's Y. And that's all that she's got. You then go to pediatrics. So you go through 14 disciplines, 2 deep, your favorite and your backup. That's 28 people. That's a very narrow network. And I found that if you can bring data to the primary care physician, the one who's referring, if a particular physician is rogue, costs too much, it's not getting the right results, they change on their own. It's not a formal process, but it's very quick. So to me, an ideal situation would be an on-site clinic to handle as much as it can, and then an RVP wraparound that makes certain that those specialists, when needed, that go outside this very narrow network, and hospitals carry out the day.
Hey, Ernie, I'm sure some of our audience, with smaller plans, what is there a rule of thumb for when on-site clinics make sense for, number of lives in a particular area?
Yes. To go straight to your question, I believe it's 500 employees would justify an MD and a nurse practitioner on site. However, my experience has seen groups as small as 90 employees. Now, the clinic's only open 1 day a week, but employees have a remarkable ability of choosing that day when it's free. There's no copay, no deductible. And if you think about, Scott, when you make an appointment, you're giving maybe 3 weeks on such and such date. You don't know if the doctor's only open that day. That's the day that you're given, and it's acceptable, so you go forward. So I think employee patients can accommodate. Now, if you're 20 employees, then I believe you need to cluster. You need to be in the same geographic area, same industrial park where you share a clinic. So that's 3 flavors to your question.
Great. I did want to make one quick comment. I don't want to go too far back in the conversation, but Ernie asked a really good question about Medicare as a benchmark and, what happens if you have a pediatric claim. And I wanted to add a couple things to what Heath said. One is, as Heath said, Medicare doesn't cover all types of services. And so it's important to have multiple benchmarks. And so if you are doing RVP, you want to make sure that you have the right benefit language that has multiple benchmarks in your benefit plan. And then the other thing is, consider your stop loss policy. If there are some stop loss providers who will put a kind of a cap in the policy and tie it to Medicare. And I guess the question would be, what happens if that's a service that Medicare doesn't cover? What kind of stop loss implications are there for that? That's all I had. Heath, where are we going next?
Well, I was
the comments.
Ernie have more? No. Okay. So this is more. It's kind of a 2-pronged thought. Scott, you might have some input. Julie, I'm kind of looking for your perspective from a stop loss and underwriting reimbursement standpoint. But there's multiple flavors of reference based out there. As I mentioned earlier, you've got some that are very pure reference based. Others are blends of narrow network or layers of network. Some are masking networks and repricing to something different. I'm curious, from an underwriting standpoint, Julie, how you guys see that. And do you find any surprises down the road? And how do you handle that?
In terms of what the repricer is really doing, is that what the
Well,
kind of surprise?
Well, one from a initial underwriting, you're looking at, you could have a plan with 6 degrees on it. You could have a plan with a different alternative RVP type methodology. Does that impact how you view that underwriting? And
Yeah,
then
absolutely.
second question would be, some of these alternative approaches to doing reference based, are you seeing things that might be sold one way and the result is something different? And how do you handle that in the end?
Yeah, we definitely have different pricing depending on the flavor of reference based. One of the things that has a big impact is whether it's fee based or if they're taking a percentage of build or a percentage of savings, because that's a significant additional cost for the stop loss carrier if we're covering a percentage of build charges or percentage of savings. So that is obviously reflected in the pricing for the stop loss. In terms of just let's say most of the vendors that we work with, we've worked with for a while, but let's just say there's a new RVP vendor out there and they're not taking any fees that are a percentage of builder savings. So, we're getting to know them and what the plan is going to say and what they expect to negotiate. And we are allowing them to have some flexibility within the stop loss policy. But we are looking at that at renewal time as well. We're looking at it as claims come up, but we're also looking at it at renewal time. We may, if we've had claims and we're not confident in what's going on, we may ask for savings analysis. In theory, we should probably be doing that on all renewals, but since we've got the books of business with most of the vendors that we know pretty well, we don't do it all the time, but we look at the savings analysis to see what they are actually, pegging to Medicare and to see if it's what they represented, because our price assumes that, if they said they're not gonna, if they said they're gonna average 160% of Medicare, let's say, well, that's how we price it. And if they're in fact coming pretty close to 200% of Medicare across the board on stop loss claims, well, that's going to impact the renewal increase for the client. So that is something that we have to look at in addition to the model of the RVP vendor. As far as other things that are going on besides RVP, I think one of the biggest things we're starting to see now is either 501R or some other sort of policy language that if transparent data shows, for example, that this is what the hospital is supposed to pay on average, and this is what they pay cash, there are some, we're seeing some policy language now, and I'm talking about plan document language, sorry, not policy language, plan document language in some plans that say they won't exceed the cash price, for example. So that is a different form of a reference price. So even if they have a plan that is generally represented at 150% of Medicare and the cash price is a lot lower than that, we may be seeing better results than what the RVP alone would deliver. And I think that's what we've seen most often recently are those kinds of plans. But we're somewhat selective in the vendors that we work with too. We have been through, or I personally, not just with Skyward, but in my previous life, I did work with some of the other earlier programs where some TPAs had a relationship with an RVP vendor, but they were really doing a lot more of it in-house, and maybe they weren't, so maybe we knew that RVP vendor, but what the TPA was actually doing was not sending most of it to the vendor. And, we got some surprises and had some aggregate claims and had some results that, you know, really did hurt the client at renewal because those TPAs weren't doing what, you know, was represented in the plan language and in the, and by the RBP vendor. So, you know, that hurt the client, I think, in those instances.
Mhm. Yeah, and I'd throw in a couple examples of some of the stuff that I've seen. You know, you talk about network plans. You know, if you say a plan puts a network logo on their card, you know, some networks, especially maybe in the physician side, you know, presenting the card at the time of service doesn't bind the plan to the terms of the network contract. Those, you know, the binding event, if you will, is really that network being called out when payment is made. But again, you typically see those in kind of these physician or wrap kind of networks. On the hospital side, you don't typically see that. And, you know, the most common triggering event in a network structure is the card's presented at the time of service with the logo. The hospital says, okay, I'm going to get paid according to X PPO terms. And some plans have as a strategy to deal with maybe an access issue, ran a network logo, and then not comply with the terms of the network contract when it comes to payment. In other words, they'll just pay the RVP price according to the plan doc. You know, you're not going to get away with this with major networks, of course, but, you know, with some of the junkier networks, that works until it doesn't work. But I think, you know, you should be considering the potential exposure to the plan, especially from a stop loss perspective, because as Julie mentioned, you know, they're underwriting these plans a certain way. And if somebody's running network logo and then, you know, you get a catastrophic claim roll through and it's big enough to get the hospital's attention and they want to enforce the terms of the network logo that you're running on the card, you could have a problem there. Julie, I don't know if you have anything to add to that.
Yes, Scott, as evidence of what you just said, Baylor Hospital sued a TPA in Texas for the very reason, the fact pattern that you described. And it was a very expensive, unfavorable outcome for the TPA.
Yeah, and Ernie, didn't that one, you know, once they find the problem, then they want to go back and look over the years and look at all the claims that they didn't pay correctly?
That's exactly what they did. Were you advising the plaintiff's attorney?
I do a little work on the side, yeah, but you
know. Heath, there was a question that came in through the chat. May I respond to it?
Yeah, I see that one from Horace there. So.
The question from Horace Garfield asked, isn't on-site clinic a form of DPC? The answer is yes. DPC is direct provider contracting. And when you've got a physician on site, that's about as DPC as you can get. A difference that I can offer is that with an on-site clinic, you've got a given physician or physicians at a given time. The location is generally on site. Whereas DPC, you're using the facility of the doctor or a set of doctors, and they participate in the DPC arrangement. So there are some variations, but in general, I would say it falls under the DPC overhead. One site personal comment about Horace Garfield. He and I were at a SIA conference in Washington, D.C. We were in the Capitol Rotunda, and he was standing underneath President Garfield. And I went up to him, I said, "Are you guys related?" And he said, "Yes, that's my great-great-grandfather."
Wow.
I was not aware. Horace, all these years, you never mentioned that to me.
I think we all have horror stories. We could do a whole fireside chat on
Horace.
Yeah,
it would be interesting. Yeah. We could have Horace on. We could talk about it.
Heath, do you mind if I switch to IDR and ask David a question?
No, let's do it. I was just going to say we've got 15 minutes left, and as an audience, if you guys have questions about anything we've been talking about or maybe talking about, feel free to ask those questions. But current moment, it doesn't look like we have any in there, so let's Let's move on to David.
All right, here's the question, David. Correct me. But if you're in an RBP situation, reference-based pricing, you have no network, and therefore every claim is technically outside the network, and therefore a surprise claim. And if there's a dispute, it goes to IDR. What's your thought on that logic?
You're generally speaking correct in that assertion, and that yes, any RBP plan that treats any claim as out of network is gonna fall into the NSA process, assuming that some of the specifications are met. But generally speaking, an emergency room claim is going to be that, and then air ambulance, not ground ambulance for whatever reason, but air ambulance as well. So those two are the most frequent ones that come up.
Okay, if that is true,
Hmm.
then are we not inviting RBP to invite IDR, a dispute resolution on every single one? And if that moderator, if that mediator cuts the baby in half,
Mm-hmm.
then the claim savings we expect from RBP are going to be diluted because they're going to be mediated between the hospital price and what the RBP is.
Again, from kind of sort of a general standpoint, maybe, yeah. But what we're seeing in actuality is that the IDR resolution process it varies provider to provider, claim to claim. There's a lot of variables in there, so I would be very hesitant to make a blanket statement saying that you're always going to be kind of shooting in between the two offers or whatever. It's also the mediation process itself. It's a process referred to as baseball style arbitration that actually came up out of Major League Baseball, where instead of the arbitrator making their own independent determination, they have to pick one of the other offers. So it's not going to be splitting it in the middle. It's either they take the provider offer or the plans offer. So, splitting in the middle isn't necessarily the best way of describing it. So, and we are seeing also in terms of the process itself, sometimes providers will only be challenging a specific line item. They'll only be challenging the primary procedure code, the 99283 or whatever it is, because that's where the big money is. But when you look at it relative to all the other items on that claim, and they're not challenging anything else, what's okay. I mean, I might even be fine just losing that IDR, knowing that nothing else is going to come up under discussion, right? Nothing else is going to be part of that challenge. So, that's all kind of part of the calculus as well, and looking at these claims. Generally speaking, I was talking about this the other day. I will say that this NSA process has been favorable to our industry in that it's brought unreasonable providers to the table. It has made the negotiation process easier to transact and easier to handle. IDR itself is also just the second part of the whole process. The first half of it is the negotiation part of it. So in that standpoint, it's been incredibly successful. And I think overall it's been very good for our industry.
Very good explanation. Thank you.
You're welcome.
David, anything else on the IDR, NSA? I mean, you're knees deep in this stuff every day. I know it's been something. One thing I can say, going back over the years that I've been in healthcare, things are constantly changing, and there's things that come up, and we're like, oh my gosh, what are we going to do with this? And eventually we figure it out and become experts in it. But what have you learned over the last couple of years? I mean, what can you share with the audience?
No different. And actually, honestly, the entire industry has been learning as the process has been unfolding, because when it started, at the beginning of 2022, you had 3 government departments that are supposed to be implementing this, right? Right there is a recipe for disaster. You can't even get 2 government departments to figure anything out, let alone 3. So, but it's also the IDR process relies on third-party contractors who have very little to no oversight that I'm aware of. The process for the first year and a half, 2 years even, was incredibly, I refer to it as a wild, wild west. It was almost like you had no idea what to expect, what was going to happen. I don't think, the providers plans, a lot of people, it was just a lot of confusion. The regulators didn't know what was going on. There's litigation that got involved in Texas, and it's just a mess. I think we're kind of finally getting out of the dust and starting to kind of see what the landscape is like, and providers and plans equally have realized, okay, here's what the process is like. Here's how we're going to go about it. Make sure deadlines are met. We had a problem for the first couple of years of providers balance billing patients. This was a big one, actually, because they didn't understand. They didn't know. Oh, there's this whole process. And then, but even in terms of rectifying that situation, it was a slow process to get those situations resolved. So, I guess generally speaking, I'll say that it's the path is getting a little bit more clear as we keep going, but we're all learning as we go along the process for sure.
Excellent.
Sure.
So we got some questions that are starting to come in. Did anybody have any follow-up comments around IDR before I start hitting some of these audience questions? All right.
There's
okay, I'm going to try and.
Hey, Heath, there's an IDR question in the chat.
Do you see it? I'm digging through them, but.
Yeah, I can do the chat real quick since we're on IDR, and then we can move. It says, aren't some BUCA plans refusing to honor the IDR determinations?
I have not heard of that. I don't know why they would. I mean, once you're involved in the process, it's a binding process, and that's what everybody signs off on. So,
I wonder, David, I'm no expert on this, but I've heard that there's really no enforcement mechanism built into this, I think, other than just complaining to the DOL, and that that may be part of it.
And again, this is again because you have three different departments, and if you're dealing with it from like a patient side, you deal with CMS. If it's from the plan payment side, it's through the DOL, and so it is a little bit of a mess. I can't even think of actually. I was thinking back to the BUCA comment. If you're thinking it's a BUCA because there would be a direct contract, then I guess the NSA wouldn't apply in that situation. But otherwise, if it's an out-of-network emergency room claim, you're in the process and you have to go along with it. So, I'm sorry, Scott, what was your other question?
No, that was it.
Okay.
Yeah, we can move on. Heath, you want to go on to the
David?
All right, so
David, a question.
Go ahead,
Ernie. Thank you, Heath. A question about IDR. Do you see more IDR claims coming from the RBP process or from the non-RBP, non being PPO?
Well, like 99% of our clients are RBP, so I really couldn't speak to that. So
But
yeah, for me, it's all RBP.
it may not hurt just to quickly go over what the scope is for the IDR claims. I know, like we talked about this years ago and people kind of forget. So like generally you're talking ER, right?
An out-of-network emergency room claim, either facility or professional. Air ambulance, specifically air, not ground. And then this is the one that gets somewhat confusing, is an out-of-network professional provider at an in-network facility. And for purposes of RVP, that doesn't happen very often, if ever, because you don't have those direct contracts very often. But if you do, and the anesthesiologist or the radiologist wants to bill outside, then that would fall under the NSA umbrella as well.
Right. But if I'm going in, if I'm an RVP patient and I'm going in for an elective MRI, for example, that is not within the scope of the NSA.
Generally speaking, no. There are actually other protections, though. If it is something that's elective, you are supposed to get a good faith estimate. And I can't remember. I think it's within 20% of that estimate. The provider can't exceed what they end up billing you. And if they do, then you can make a complaint and go through a process as well. So there are actually protections from the elective side. But generally speaking, no. We're talking about emergency room claims and things that, I mean, the process was designed to keep the patient out of that process, right? Because you're going to an emergency room. Why should you have to decide who's in network or any of that, right? That's not your concern right then and
Ernie. Another one for you, David. How often do you see claims go to NSA?
To the NSA process, again, that's kind of relative to claim volume.
Arbitration.
I guess actual arbitration. I would say probably less than 10%, even like maybe 5%, I would say. It's very low, because the negotiation process has worked to bring people to the table. And it's usually, you can tell, and especially in terms of that part of the process, you can tell, you can read the room really quickly when if you're dealing with a reasonable provider or someone that's just going to dig their heels in the sand, and draw the line or whatever, and they're not going anywhere. So it's more times than not, you can even know what you're getting into before you even get into it. But I'd say, yeah, 5, maybe not even, yeah, 5-ish% or so. It's very low.
Okay. So we're getting into the power answer questions here because we've got to keep these quick. We got 5 minutes to go and we got to close things up too. So can you address the informal negotiations and what happens?
Formal negotiation process. This is just so this is when the providers, they're submitting an open negotiation notice. It's been beneficial because we've actually gotten reliable email contacts for certain providers. You have 30 business days to come to some sort of resolution or settlement or not. At the end of that window is when the provider can then initiate the second half of the process, which is the IDR process. They have a very small window. It's only a 4 business day window in which they have to act. So sometimes we actually use that to our advantage in terms of technicality, and we can get something dismissed just based on timing alone. It's also important to remember it's always business days, and there are new holidays that a lot of people don't take into account, like Juneteenth and Indigenous Peoples Day. I think there's another one too that popped up on me this year, and I was like, oh, I didn't realize it's a holiday. So Veterans Day, it's a federal holiday, but not everybody honors it. So I see another question. I'll take this one real quick about what happens if a participant is balance billed for an NSA claim. Unfortunately, at this point, we've only really seen enforcement through CMS, which has been very slow. They have virtually always resolved in the patient's favor, but it has taken up to about a year from when a patient is initially balance billed to we've found resolution from CMS and them getting confirmation that everything's been written off and there's no balance and yada yada. So it's slow, but it works. But we had to hold some hands for some people that get very agitated about the process. But it does what it does. It's the government, so you can't expect miracles.
Okay. What happens if a participant is balance billed for an NSA claim?
Oh, that's what I was just talking about.
Oh, you just said that. Okay, I missed that guy. Got multiple. I was reading the other ones. Okay, we're down to 2 minutes. Scott, any thoughts on RBP working significantly better in particular regions?
Ooh, that's not a quick answer, but yes, I mean, we obviously have historical data that we can look at. The only thing I would disclaim there is it's a very fluid environment. So, we can have a provider that's friendly today and unfriendly tomorrow and vice versa. So it's hard to find certainty here, but we certainly can give guidance in terms of markets or particular hospitals that are being very problematic. And it's a great question because I think, again, setting expectations with plans, that's probably the single biggest determinant in terms of retention.
The only thing I'd add to that is, what do you see as RVP? There's different flavors of it. You can create narrow networks with an RVP wrap. You can have, a single provider type contract that might alleviate some of those issues. And there's other ways of going about it than doing pure RVP. Okay, we got to wrap up. I know there was another question that came in from an anonymous source that I think takes a little more effort to answer. So if you want to send me an email, whoever that anonymous attendee is, I'm happy to answer that for you. I've got some ideas, but we're going to run out of time here. I want to thank everybody, Ernie, Julie, David, and even you, Scott, for being on our October Fireside chat. It's always fun. Hopefully people find it useful. I know we've got a pretty consistent audience that keeps coming back. These things are also available on our website where you can watch any of the past episodes. Coming into next month, we will have Lester Morales of Next Impact. This guy will bring the energy. He's always entertaining with a great message. So look forward to seeing Lester November 13th at 11 o'clock a.m. Pacific. So thank you guys. Appreciate everybody's time. Enjoy
Thank you.
the rest of your day.
Thank
Take
you.
care.